Good morning. Thank you for inviting me to speak at this important conference organized by HERA on the lessons that can be learned from the pandemic. The fact that I have to speak to you via virtual means is already an illustration of what the pandemic is doing with our countries and with the way how we connect with each other. And I'm very happy that HERA this way tries to organize a conference where we're not focusing just on the acute effects of the pandemic and our day-to-day problems, but tries to have a broader reflection on what the consequences can be for the healthcare systems in the longer term, but also what opportunities we have of restructuring and redesigning our healthcare systems to make them more resilient for dealing with the pandemic. Of course, as being a representative of an organization for economic cooperation and development, you can understand that the OECD takes a broad economic focus to the crisis. Actually, in the past 7 months, several parts of the OECD have been working very hard with member states to trying to understand the phenomena. And as you can see on the website where we have a Corona Hub, there is an increasing amount of reports, video conferences, and advice on how to deal with the impact on different parts of the economy. This is just a shot from yesterday, and you see a series of reports on the impact on schools, digitalization in schools, effects of international taxation, also looking at the way of how the crisis can be used as a way of restructuring your economy and make it more greener for the long term. Many opportunities, and the OECD tries to follow these debates and tries to be proactive in providing information to member states on how to move forward. This is not the focus of my presentation today, though. I would like to discuss with you some lessons learned about the future of the performance of healthcare systems. And behind this lies the idea that if we want to learn and manage the pandemic with respect to our healthcare systems, there are at least 4 types of information that we should collect. Of course, everybody is now focusing on the first type on this sheet. A lot of epidemiological data, COVID-19 related data, like how many new infectious cases, how many people are tested, how many people with coronavirus are admitted to our hospitals, how many people are at the ICU, and how many people die because of COVID. That, of course, is important information to manage the direct spread of the pandemic. But to really manage your healthcare system, you also need information on the impact on the rest of the system. What is it doing with chronic patients going to your general practitioners and your primary care system? What is it doing with postponing elective surgery? What is it doing with people asking mental health care? Or what is it doing with the capacity to provide home care services for the elderly people who need it? And the third area of information is the behavioral insights. What is this pandemic doing with the behavior of the citizens? What do people think about it? And are they willing to comply with measures that governments are imposing? A very important piece of the puzzle where we need continuous information of how we can make this really a community effort. And last, but surely not least, we need information about the socio-economic impact. And again, that's one of the areas, especially the economic impact, where the OECD is looking at. So I'm very happy to share with you some lessons and opportunities learned with the experiences during the past 7 months. And I just would like to acknowledge in my presentation the many debates we had within the OECD and with the member states and with students I have the pleasure of working with at the University of Amsterdam. And I particularly would like to thank the Harkness Fellows Symposium, where this same topic was discussed a few months ago, and work done by an international group of fellows in the Health Pros program who are looking at the dashboards worldwide. So if I look at the lessons, and I will present 7 to you, the first and foremost point I would like to address is the necessity to improve access to high quality care for vulnerable groups in your population. And what we see increasingly in studies, especially in the US and in South America, is that vulnerable groups, and especially people with a lower socioeconomic status, are hit most by the pandemic. That's partly because they have a higher risk of getting infected and needing treated. And then, of course, the question is, do they make it to the hospital? But the other part is also that their other medical concerns might be hampered, and they are most likely also the group where the impact of the economy, meaning getting unemployed, is coming first. So it is an important area to look at, and several countries have picked up already actions where they try to support vulnerable groups, minority groups in their society, and give it specific attention. On the other hand, it's remarkable that when the students I'm working with were analyzing 158 national and international dashboards on COVID-19, so information that is in the public domain, only a small minority of these dashboards provides information which is disaggregated by race, ethnicity, or socioeconomic status. This is a slide from that work, and you see that the type of breakdowns you find on, for example, who are infected or who are the people who are dying, many of the dashboards seem to have a breakdown by sex. More male than female are affected. By age, we know the elderly people are more affected. But when you look at a breakdown by long-term care, do I know the specific number of people who died in long-term care facilities, or by race, ethnicity, and surely by socioeconomic status, this information is largely lacking in the public information we have available. And this was based on data collected in July. So this would be one of the pleas that if we want to address these disparities, it is important to make it visible, to try to disaggregate in our data which groups are hit most and try to see whether we have policies in place to address them. The second point and lesson I would like to bring forward is that we learned that a strong primary healthcare system is now even more important than ever. Of course, strengthening primary healthcare systems has been around for 50 years and is reiterated again and again. But we see in OECD countries that those that have a strong primary care system that can deal with chronic diseases, with immediate concerns about COVID, that can deal with initial testing and basically also reducing anxiety within the population, that it also mitigates the amount of people coming to the hospital. And in that way, making it easier for hospitals to deal with the increased demands, but also not posing new hubs of infection and spread of infection by having people waiting in crowded emergency rooms. So a strong primary care system is important. And in this period, it's even more important that primary care is well aligned with the classical public health structures. So when you think about the studies and the identification of people with coronavirus, but also with influenza, which is now a problem in Europe, where we are in the beginning of the winter, but also issues like screening policies and upcoming vaccination. Having a good link between your primary care system, which is quite often private organized with private practices, and your public health system, the regular public health, is essential for making this work smoothly. I'm mentioning here a report that was released in June by the OECD, not particular on COVID, but it gives an overall impression of how countries can realize the potential of primary health care. Is the importance of flexibility. and flexibility in the upscaling and downscaling of your critical care capacities. So how good is your system in all of a sudden being able to absorb a lot of COVID-related patients, whilst at the same time controlling the need for the regular patients. So that means the need for responsiveness in your total bed capacity, but also for specific technologies like ventilators and ICU. And that resulted in many countries to a national or regional sharing of capacities. In Europe, I've seen countries really try setting up out of the blue a more national or regional coordination of capacities, making sure that if one region of your country is affected by COVID, that part of the patients could be transported to the part of the country that is not affected. Or that's for COVID patients, but also for your regular patients. And even between countries, in my own country, the Netherlands, where I live, we actually have arrangements with Germany that some of our patients, COVID patients, went to Germany, and now for the second wave, there are again arrangements. So all of a sudden, there is the need for governance structures that can really plan this capacity, and that also means that the boundaries between public and private providers are changing. I've seen that in some countries with a huge private delivery component, like Australia and the Asian region, but Ireland in the European region, government intervened and starts looking at the whole capacity and tries to overrule and see how can we maximize what is there, either public or private. But to do this, of course, you need to have timely data, and you need data that can help you to balance the COVID patients with the rest of your healthcare system to get an optimal use of available resources. And that, of course, is also a process where information is key. Beginning of October, there was an international conference of choosing wisely. I just want to make the link that this also has to do with an opportunity to really think critically what care is really needed, what care can be postponed, and where is waste in my system, or are things done, testing capacity use, for example, for the things that seem to be less useful when you have scarce resources, because that's the situation you're in, and every country will face that when they have to deal with the outbreak. The fourth is the effect on integrated care. We've seen during the first phase of the pandemic that there was more and more need for hospitals to start communicating with primary care, with home care, with mental health care, with social care. So there is a big push towards integrating the care services in a certain community or region. So a reorientation on local communities, networks, and regions. Of course, that was already in place in some systems, but those systems where it's very separated, integrated care has really become part of the dialogue, how to structure the healthcare system for the future. And the increased use of digitalization and teleconsulting helps with that. It's no longer just a one-off consultation and visit to a hospital. It's how do we set up a system that facilitates citizens to communicate with all kinds of providers in that system, but have continuity of care, have long care, term care trajectory. So integrated care and integrated delivery systems are a focus point. And in the recent meeting of the Working Party on Healthcare Quality of Outcomes of the OECD, this is one of the main themes, and it will be in the working program for the coming years, to see how through data collection and governance systems, countries can try to make that shift to a more integrated care delivery. The fifth point I would like to make is the need of a flexible workforce. And the point here is that we see at the times of a pandemic and a crisis that we need flexibility within and between different groups of nurses and physicians. Of course, safety should be the first concern. And we also saw, especially with nurses working in community care and in long-term care, that there have been situations where professionals also felt unsafe themselves and then stayed away from their work, and then absence rate in some of the European countries in long-term care and nursing homes was very high. So first and above all, assure the safety of the healthcare workers. But within that, it is good to think about the possibilities of task substitution between and across medical and nursing professions. So we see that in a situation, also in a hospital, all of a sudden nurses who are used to work on internal care ward are asked to work on the emergency ward. Some of them are working at the intensive care unit. That, of course, needs regulated. We need a careful balance between the skills and the capacity of people, their safety, and the flexibility in the professions. And for the long term, that's also a task for the regulatory bodies to see how they can change this, that not part of the medical workforce is not working and contributing to COVID, but we really could see how can we use all the competences we have. And some countries are thinking about, I call that a reservist approach, but can we think about having a supplementary workforce that we can mobilize when it's necessary? And can we train it in such a way? And again, some countries are using parts of the army to pick up their tasks, but you could think in the longer term of having a far more flexible way of upscaling, downscaling the workforce. With respect to safety, I just want to draw to your attention 2 reports that the OECD released on Patient Safety Day, September 17th, which was focused on the safety of healthcare workers, one on patient safety in long-term care, and one on patient safety governance, just as background information, how this topic can be picked up. And I also put here a reference to a report on measuring safety culture, which we found in the crisis, and I'm now referring to a study I was involved in Portugal, to be a very important aspect. If workers don't feel safe, if they don't feel that they get supported, especially in long-term care, by their management, then you have a problem in having them giving optimal care during the pandemic. So it's an important element to look at. The 6th, and that was already very much linked to all the other items that I brought forward, is of course then the information infrastructure. And you see here listed some of the various points why policymakers need reliable and especially up-to-date information. If I want to monitor the situation, I need to know the occupancy rate in my hospitals today. And I don't want to hear that well, it will take 3 months via the administrative data to make it available. So there is a lot of debate about optimizing the data infrastructure, and especially how to use the various sources like clinical registries, administrative data, the electronic health records, and the linkage, and the survey architecture. In essence, and this is repeating again the message that we need data to evaluate the initial response to COVID-19, but we also, and very much so, need data to ensure the progress that we achieve in improving health outcomes for non-COVID-19 related conditions. For that, the information infrastructure should help us. I'm now showing just very shortly some slides coming from Canada of the type of information you would collect. This is, for example, the change in the use of emergency care. What you see here is a comparison between 2020 and 2019. And on the one hand, it signals the drop in the use of emergency services during a severe phase of the first phase of the pandemic in Canada. The other thing, it demonstrates that the data became far more quicker available than they were before. They call that open year data, but you not wait till all the validation has been done. You need to have the data now. And this is, I think I like even better. You want to monitor basically how the different parts of your system are reacting. Here you see the change in the visits to general practitioners, the number of consultations in home care, the overall use of beds in clinical care, and the visits to emergency departments. This will be part of a report that comes out in November. But if you are able to monitor the impact on the use of the various parts of your system, you're also able to react timely, not to just focus on the COVID patients and hence creating perhaps even more problems with your chronic patients or in an area like mental health care delivery. So information infrastructure is a very important item, and the OECD has been addressing this since 10 years. You see here a series of reports that came over the past 10 years about strengthening your data infrastructure, how to organize the governance of data on a national level to have it optimal. There's actually a council recommendation in 2017 of the ministers about this. So this is an area where the OECD also would like to work with countries over the coming year. And in the meetings beginning of October, we launched the idea of having country reviews, willingness to come to countries to see how their information infrastructure could be strengthened and what lessons could be learned from the pandemic so far. Just to show you the heterogeneity and why this is relevant, this is a slide that will be in a report that was published later this year. But this is an attempt based on the surveys of the OECD to map, on the one hand, the data availability and the maturity of the databases and their linkage, and on the other hand, the specificity of the governance model. Of course, you can criticize the way we did the mapping, but it shows that we have a lot of differences between member states in the strength of their data systems and their governance. And as you can see in this slide, Korea is surely in the right hand corner, the better ones, but I'm pretty sure that also in Korea there are lessons to be learned, and vice versa, by the way how South Korea is managing things could be a lesson for many of the other countries. This brings me to my last lesson. This will only work when governments are able to build trust in their healthcare policies and in the healthcare system by dealing the pandemic effectively. And trust is a difficult thing. Of course, it can also be measured, but it started in the first phase of the pandemic by having especially sufficient materials like protective equipment, having sufficient testing capacity, having a functioning test and trace methodology in place, and having sufficient hospital beds and ICU beds. Of course, this was the immediate concern in many countries because most of the countries haven't prepared for this huge increase in demand on their healthcare services. But trust is very much dependent on the extent that governments were able to deal with this initial response. Of course, we're now in many countries in the second phase of the pandemic, and then you see that the trust is even more important to make sure that the measures that are taken are communicated in a way and presented in a way that is appropriate with the culture and political climate in a country. So in this phase, communication becomes more and more important because it will, for the longer run, difference between a short sprint and a marathon, it will be very hard to convince the public to keep on complying with the measures, and that should be culturally adaptable. But for sure, public information and communication are key elements here. That's again why I'm stressing the need for having good data about the situation. And that means not just about the number of cases, but also showing about how the rest of the system is doing and basically informing people about how the rest of the country is complying with the measures, because only in that way we can really help to get over the pandemic. So far, I've presented you 7 lessons and opportunities to improve health system performance. I won't go over the 7 again, but I hope they are useful, and I hope they can be used over the coming days in your conference, but also over the longer time as topics where we can not only learn from this pandemic, but also use the big changes that are now happening as a way of improving. learning and improving. So thank you for the opportunity for sharing this information with you today. And thanks also to HERA for facilitating this kind of conference, of offering an opportunity to reflect in a more distant way of how to proceed over the coming years, just to try to stay away from the crisis of today. We're trying to see what does this mean for our system design, for our data infrastructure, and the things that we could now change that were very difficult to change in the past. So I wish you a very good conference, very good deliberations. And I just would like to say, well, stay safe, but stay connected to the OECD. We are very much looking forward working with you and all the member states to share the intelligence and trying to deal with this pandemic together. Thank you very much, and looking forward to stay connected.